Let me start off asking some questions. Patient, large pulmonary embolism, decreased blood pressure in the emergency room. What are we going to do next? We've got a CT scan that shows that there's a saddle PE. What's the next step?
So ongoing resuscitation, I think that's probably the first thing, right? Ongoing resuscitation, prompt anticoagulation, and then the question is how hemodynamically unstable is that patient, right? So if they're in frank shock and don't respond quickly, then I'd say that's a patient that should have systemic TPA and maybe consideration for ECMO. Our experience with ECMO here has not been so great, so I don't know if I'd be that big of an enthusiast. If they're more stable than that, then I think you consider catheter-directed therapies. But the main thing first is to anticoagulate and stabilize the patient, resuscitate them.
Yeah, so one of the things that was brought up this morning at our conference was intubation in patients with pulmonary emboli. And I must admit, I've often thought if you had a patient you're going to transfer, that intubation would be a reasonable thing to do to stabilize them. However, there was, Dr. Channing in particular had very strong feelings that that is the wrong thing to do in these patients, that we should avoid intubation. Anyone want to make any comments about that? We're talking about intubation in the patient with a big PE, Tom. You talk about the RV.
So I do think that, pardon my absence for a few minutes, but so I do think that in general, we always think about stabilizing the airway in unstable patients, and I would suggest that in patients with significant pulmonary emboli, just like patients who have pericardial tamponade, that may be one of the few exceptions to that rule. That you take somebody, the amount of afterload that you put on the right ventricle from positive pressure ventilation can change a metastable situation into a very unstable situation. So if you're going to intubate them, you may want to intubate them in a place where you're planning to do a more definitive therapy for them.
Anybody got any questions from the floor? Please hold up your hand. All right. Uttam Tripathi. Dr. Tripathi is one of the heart surgeons out at Sugar Land and does quite a lot of PE interventions.
Thanks, Tom. I think that comment is very, very important. In the initial series of patients that we have done about 200 catheter-directed thrombolysis over the last 5 years or so at Methodist Sugar Land, and we were part of the trial for the Optalize PE just finished. We lost 2 patients early on, and both patients we learned the hard way. The initial response is intubate is unstable, and they are just surviving on the adrenergic response and the preload that is there filling the heart. And one we did put an ECMO, we know arterial, but didn't work out. So intubating these patients are really, really not a good thing.
That also does depend on the agents you're using, right? If you're giving the patient a big load of relaxant agents and stuff, then yeah, they lose their preload and their pressure drops, and they're probably done. They're going to rest right on the spot. But I think that's where, when we've taken them to the operating room and CV anesthesia's there and puts them together with careful,
So we have a couple of our CV anesthesiologists sitting in the back row who are very quiet. Don't you put a microphone up there to Dr. Athanasio? So I bring the patient in, the patient's not doing well, so you got to intubate this patient, Nick. What are you going to tell me?
Well, ideally we try to avoid intubating them because in a patient that can be semi-stable or semi-unstable but not totally unstable, you introduce other parameters that can make them totally unstable. So the ideal is to try to avoid extubate them and keep them breathing spontaneously. Now, as Dr. McGillivray said, if the need arises to intubate, the best place is to be where you're going to do the major intervention if you have to intubate.
If you have to intubate, then I think we should put the ECMO first.
Okay. So go ahead.
I have given patients who are metastable local anesthetic in their groin and either put them on ECMO or actually put them on bypass before intubating them. You can do that, but those are obviously selected situations. Now, I would hate to have the message be that you should never intubate these patients.
Yeah.
You have to if somebody's arresting, you have to intubate them. You have to use your clinical judgment. But on the other side of that, you don't have to intubate all of these patients because they're dyspneic.
Okay.
Electively intubating, I think it's not the right thing to do if they're not too unstable.
Okay. Okay, Dr. Rozovsky. Inferior vena cava filters. We talked a little bit about this at lunchtime, but damned if you do and damned if you don't in this situation. If you don't put it in and something happens, you get the blame for not doing it. So how do you use them? I mean, and at MGH, what are the indications for using a filter in a patient who's had a submassive PE?
Yeah, so I think it depends on the person. I think there's people that are definitely anti-filters in our group, and there's people that are pro-filters. And I think we try to make an individual choice for each person, but obviously if they have a contraindication to any kind of anticoagulation, you need to put a filter in that person. I think what gets a little bit difficult to decide is when somebody has a huge PE and also has a fairly large clot, and what we worry about is, wow, just another little piece breaks off and that's it for that person. And in that sitting, we have put in filters. I'm not saying every single patient like that, but if they have a big PE and they have a tiny little clot, we tend not to, but we have done it in patients that have, even though that's not really the standard of care, because of lack of guidelines, but that is a situation where we have done that.
Any other comments about use of filters? I'll leave a microphone over there. Dr. Tripathi. Yeah.
While they're passing on the mic, I would say that some of our cases have been that somebody's going to get catheter-directed therapy for PE, and when we're doing the ultrasound, we see a big clot in the common femoral. It's sometimes not attached, looks like it's free-floating. If that thing launches and they're already in the submassive category, we worry greatly they're going to flip right over and either die or go into massive PE category. So for patients, we've done that not uncommonly. I don't know if you guys have had similar experience.
So does free-floating thrombus, should it change our indication for putting in a filter? It's pretty alarming when you do a cavogram and you see this giant thing, kind of like a sea anemone, wiggling around inside the inferior vena cava.
And you're starting to drip TPA.
Yeah. But Eric, it goes up to the renals. Are you going to put in a suprarenal filter?
If the clot is up there. So I guess the question is, are you lysing the cava or you're lysing up top?
Lies in the PA.
Yeah, well, then you'd wonder about sort of the case that they showed earlier, right, where they went in and suctioned out the clot and used some other device first to try and get that bigger bulk in. But if not, then yeah.
All right.
Isn't it too, if you look at that graph of patients who die from acute PE, a number of those patients who don't die right away die from a subsequent PE during their hospitalization. And at least it makes sense that if you put a filter in those patients, you might prevent those. But what are your thoughts about
Uttam?
that?
Yeah.
Well, those are the patients that are not included in those trials, though, right? That's the challenge.
I think there's not a lot of data, but I think that's what we face all the time. We worry about that all the time. And then the question is, you also have to worry about the complications of the filter, because once you put that filter in, it could clot off even very quickly. We have some data from our group that shows even very quickly it can clot off, and then it's difficult to take it out. But I think weighing the risks and benefits, and that there's really no great guidelines, but that is a fear we have a lot.
So what we have been doing is we were putting in filters for all patients who have common femoral DVTs and above. Of course, not the IVC. Common femoral DVT and a PE, we were putting in a filter, taking it out within 5-6 months. Lately, we have been kind of hesitant, even in some common femoral DVTs. We are seeing how much PE they have, the bulk, and what compromised situation they are existing in. We are very, very keen on taking these filters out unless they have had repeated PEs arising from below, and we talked to the hematologist about that. But what my question to Alan is, we are getting all these.
I'm the moderator. I don't take questions in this particular
What do we do with these filters that are 2 years out, 3 years out, and Methodist is sending letters and they're all coming back asking,
My gosh.
what do we do? I'm not going to take out, I don't feel comfortable taking out filters 2 years, 3 years. There are some people who maybe, what does Imran do? I don't know.
Yeah.
I leave them in. If they've been in there for 2-3 years, unless they're poking into duodenum, and even in those cases, if they're stable, I just kind of watch them.
The problem is, though, that those complications happen in a delayed fashion, right? Yeah, and it's been really controversial. I guess I would say that I'm probably to blame for that. And the reason being, the thing that kind of inspired me to go to quality and say we had to do something is that patients many years later, after having these filters in, came in with pieces in the heart, pieces in the lung, all kinds of stuff, right? And you look back and the patient's like, geez, doc, why didn't you ever call me and tell me to come get this thing out?
So
Because
can
unlike
I just
everybody
fill
else
in
in
a
the
little
world
bit of the
that doesn't
background to those questions? Is that, probably everybody here's seen those ads that are running on TV, call 1-800 malpractice attorney for your inferior vena cava filters. I've got pictures of my TV in New York, in Vegas, in San Francisco, and Houston, because these are running nationally. And so we've been getting a lot of calls from patients. So we ran the database at Methodist, mainly here, and there were nearly 3,000 unretrieved filters in the past 10 years. And that became and some of that, of course, is completely appropriate, but some of them may not be. And in order to try and obfuscate some of the questions that we were getting from people calling the office, we sent out these letters, basically said, we have a record that you had an inferior vena cava filter placed. Please contact, if it's not been removed, please contact the physician who implanted it for further discussion. Oh my Lord, have mercy. This has opened up a bag of worms that we had not anticipated in a variety of different ways. Most people were very receptive. Some people were mad. Some people didn't even know they had an inferior vena cava filter placed, is the interesting thing. And so, and to your point, one of the very interesting things is that we have patients who now have documented CAT scans that the filter look normal. 3 years later, it looks like a completely different filter. Saw one this week, it's penetrating into the aorta, it's penetrating the duodenum, it's penetrating into the spine. The whole thing is completely splayed out, and it's fundamentally different in 2 years. Another patient fractured in the course, basically, of their follow-up. So I don't think it's just a matter of, it's not bothering them. It's a real issue in terms of how to do this. Now, they've clearly been overutilized, but some patients need them. So anyway, I'm sorry, you were going to say something? Rachel?
Oh, I was going to say, we faced this at our institution too, and so we have a mechanism now where whoever puts the filter in, starting within a week, they get a weekly email that says, you put this filter in, when is it coming out? And they have to respond. And so it's actually cut our numbers way down in terms of the non-retrieved ones that we haven't retrieved. And Ida Weinberg published on this recently.
So is that the institution that's just taken that? Because so the challenge is, there are like 4 different specialties who are putting in inferior vena cava filters. It's not like we can fix the vascular surgery problem and it's taken care of. And so the institution has said, we are responsible for this. We are going to make sure that the communication goes out.
It's a program it's a program that's in, yeah.
The beauties of Epic. I guess I would say, yeah, that's right. So, our approach here has been that if it looks like a filter that can be safely removed, then we have removed them. And some of them have been many years after they've been placed. Most of those filters are retrievable.
Oh, because I can imagine there's a lot that's probably not retrievable, right? 10 years ago?
Yeah. I mean, some of those filters, it's amazing how easily they come out, actually. Some of them, one of our partners is pretty aggressive about removing sort of unremovable filters. There have been a few patients that have had strange complications that required surgical extraction, right? Some of these people are eroding into something or other. But I think, Dr. Mohidan's saying, if they're not having problems, leave it alone. I guess the problem is that we've seen patients that many years later start having problems. And are you going to follow those patients with yearly x-rays and that kind of stuff, or look for fracture, look for migration, etc.? There's no clear guideline to say that you should be doing that, right? The only guideline we have says if they don't need it anymore and you think it can be removed, have the thing to remove it. So that's what we've been doing. And by and large, I would say much more successfully than you would anticipate.
But I think moving forward, coming up with a program where you can, follow and be able to have that taken out.
All right, we're going to fire the questions at Dr. Gopalan now. So we heard earlier on that CT scan is the diagnostic modality of choice. How do we follow these patients up? We go in there and we intervene on the patients. Do we should get a repeat CT scan? Can you quantitate clot burden on the CT scan?
You can quantitate clot burden, acute PE, there are clot burden scores, but none of the data has suggested that clot burden scores have any impact on mortality. And
How can that be? So we're intervening because there's a big old clot and it's got right heart failure, and then all of a sudden it doesn't really matter whether there's a big old clot there.
It just doesn't seem to be. It's the RV-LV ratio rather than the clot burden that matters. So when you report CT scans, at least residents in the UK are taught to report now. Make sure that you report on the RV-LV ratio. The clot burden, the so-called the Masada scores and all that, we just don't do it. Yeah. Another thing that I wanted to touch on with regards to CT is what percentage of what we call acute clot is truly acute and what's acute on chronic. And I know we're going to touch on this tomorrow, but I think with all these catheter-related thrombolysis that you're doing and all the surgical stuff.
All right, so you're going to tell me that you can date clot. Here's the challenge, and we're very interested in this, is I think it is unconscionable that we sometimes use a life-threatening agent, lytics, for 2 to 3 days and then go, must be old, it hasn't dissolved. That there needs to be an imaging modality that says, old,
This
new,
yeah.
realizable, worthwhile trying it, not a chance that this lytics is going to affect it. You're going to tell us about this tomorrow?
I'm going to tell you more tomorrow, but it's just to say, you asked, is CT really the truth machine? And out of all the modalities that we have thus far, the one modality which has got a chance of telling you if something is acute versus chronic is CT. It's not VQ, so
Not
it's going
MR.
to be.
Not MR?
Not anymore, no. CT.
Okay.
Dr. Gopalan, quick question. The CTs are all gated, right? So it's pretty much a surgeon question, maybe dumb. Is it the CT scan that is being seen that is being captured on the systole or diastole, or because the RV-LV ratio matters?
Yeah.
Different.
So there are literature studies that show that the outcome can be predicted both on ECG as well as non-ECG gated CTs. Now, I was surprised this morning when they said most of the CTs in Methodist is ECG gated, because by and large, CTPAs that are done are non-ECG gated. Okay, that's the general trend internationally.
That was the cardiologist talking.
Yeah, so
It says CT scan and it's
Yeah.
CT.
Yeah, so I think it's non-ECG gated studies, and if you take a non-ECG gated CTPA, average you would cover about 4 or 5 heartbeats. So you will have both diastole and systole. So you're just going to have to take the widest diameter of RV and compare it to the widest diameter of the LV. If you do have ECG gating, if you've got a patient who is tachycardic, they usually would acquire it in systole. If you've got a patient who is not tachycardic, then they would have acquired it in diastole. He showed you an example of adaptive sequencing, right?
Does that matter? I mean,
It does matter, but by and large, the CTPAs that you're going to be facing are not ECG-gated CTPAs, and it should be fine for you to say. Based on that, you don't have to do the fancy 4-chamber view. You can just take a transaxial view and say, on this simple image, the RV-LV ratio, you're not going to point it to the absolute 0.05%, so you should be okay with the CTPA.
my question is, in the diastole, the RV will possibly be a little more than the LV. And in the systole, the LV will be contracting, and does it really matter, or do you have to take different 4 or 5?
You have to take
RV-LV
4 or
and
5
take a
images.
ratio,
If you
a
will
mean?
cover over 4 or 5 heartbeats if you're going to do a CTPA. So you should be just able to look at the widest diameter of the RV and the widest diameter of the LV in different slices.
Okay, another question is, big thrombus on a dialysis catheter in the right atrium. Is that a PERT problem? Is it in transit? Eric, you've seen lots of these.
Yeah, the mistake is when they get thought that they're tumor or something else, right? Those are the ones that are strange. Yeah, I mean, currently now I'd say most of those patients get anticoagulation alone unless there's something else. The tragedies are when somebody removes the catheter not knowing that it's there, and then the person has a sudden arrest or something, which can happen. Do y'all get called about that for PERT?
We don't generally know. But we'll put people on anticoagulation, and if the line has to stay, we can treat through it, or we'll keep them on for 3 to 7 days, and then think about pulling it if it can be pulled.
I can say, as somebody who spends a fair amount of their time opening up people's hearts,
Yep.
people who have pacemakers and ICDs, they almost always have some kind of clot or something on it. I think the harder you look, the more you see.
Okay, so Tom, you convinced me surgical pulmonary embolectomy is a great thing. How do you judge the effect on the right ventricle? And how do you know when you're done? You know, the disadvantage is you can't see it. The thing breaks off, and so how far out in the pulmonary artery can you actually visualize?
So, well, it depends on where you make your incision. So if you make your incision near the bifurcation, and you're at the bifurcation of the pulmonary arteries, you can see down into the left pulmonary artery, and you can see the segmental branches of the pulmonary artery. I think you would be wary to start sticking things into the smaller branches that you can't see, because certainly while you're fully heparinized, if you rupture the branches of the pulmonary artery, that bleeding will be a problem. Will be potentially a lethal problem. You can make an incision by the superior vena cava on the right pulmonary artery and see into the right pulmonary artery as well. But usually, the clots that you're pulling out in these patients are big, organized clots that come out in big pieces.
So you get the clot out, you come off pump. Should the RV be better?
I mean, the RV often, if you have a severely struggling RV, it oftentimes will not be all better. And that, so it's in relation to it's more than just the obstruction of the pulmonary artery that causes the RV to get into trouble. I mean, we do pneumonectomies on people all the time. You put cross clamps on the right pulmonary artery or the left pulmonary artery, and their RV doesn't fall apart like this. There are other factors that are involved, and but once the RV is really compromised, particularly if you're going to have positive pressure ventilation when you come off bypass, those are people who will oftentimes, at least temporarily, need pharmacologic or mechanical support.
So Nick, can you help him? And hey, Nick's too busy.
Tom, can I just ask, the anticoagulation required to put them on bypass, that must carry its own risk of intracranial hemorrhage or major hemorrhage as well, yeah?
So you would think it would, but in practice it doesn't. The risk of stroke from heart surgery is pretty low these days, depending upon how hard you look. But the incidence of hemorrhagic stroke from bypass for routine heart surgery is less than a fraction of a percent.
So Nick, the question was, Tom's done a surgical pulmonary embolectomy, he's coming off pump, you got a TE in. Can you give him any useful information?
With a T as far as if there's any residual...
Residual clot and I guess the RV function.
Yeah, the RV function, definitely we can, give information about that, but which also probably obvious if you have the chest open there. As far as residual pulmonary emboli, T is not that good in doing that. Unless
How far out can you reasonably visualize?
you can visualize up to the main PA and the division right and left proximal PAs, and that's pretty much it. But the quality of the images are not always good enough to with certainty say if there is anything left or not. I don't know if Dr. Saras...
Comments?
You certainly don't want to leave the operating room with your right ventricle struggling. You don't want to leave the operating room in these patients on high doses of multiple inotropes. You're much better off giving them some kind of temporary mechanical circulatory support, whether it be ECMO or an RVAD or right-sided Impella, something to mechanically support the right ventricle, so that and they usually do get better.
All right. Any other questions? So I think when Dr. Kanik was presenting earlier, this is a question for your PER team, was he was called by an outside hospital and they said, big saddle PE, give him a Lovenox and ship him. Is that okay?
Well, I think if the patient is hemodynamically unstable and you don't think they're going to make it to the hospital, then no, I would give them lysis. So I think if they're hypotensive and they're crashing and they can't make it to us in time, then I would. But if they are hemodynamically okay.
So Lovenox rather than just a big IV bolus of unfractionated heparin.
Oh, so there was actually an article that was just published about 2 or 3 weeks ago. It's on our pertinent updates. So one of the things we do with the PERT team is every month we send out a list of probably the top 5 articles. David Slosky is on that group. And an article that just came out was looking at low microweight heparin and unfractionated heparin, and low microweight heparin did much better. The problem with unfractionated heparin, and we find this at our institution, and again, this article found similar findings, is that it's very difficult to get people within a therapeutic range within the time that you need. And the first kind of 12, 24 hours is critical, and we look at our data and we just can't do it. Mostly people are under-bolused or they're not on the right dose, and so with low microweight heparin, there were much better outcomes because you weren't waiting for that PTT in 6 hours to get. Rich actually has an algorithm, if we do put people on, this is the Rich algorithm, that we check a PTT 2 hours later, and if it's not over 150, we rebolus them. Because again, these people are critically ill, and if you're waiting around for that to kick in, they're gonna not do well. But I think in outside hospital, if they're stable enough to get the low microweight heparin and sent to us, like that case I showed, then absolutely, because then we can do an intervention. It's very hard. I know that when Tom was with us, you know, if we gave people TPA, our surgeons do not take them to the OR within, usually wait, what, 20?
Happily, yeah.
Usually we'll wait 24 hours. We can try to put them on ECMO, get them over that 24 hours. But to try and do a procedure on someone that's just been given 100 milligrams of TPA, that's very, very scary and difficult to do.
Yeah, Richard, one follow-up question from your presentation. You talked about not screening for malignancy other than kind of the usual parameters. What about hypercoagulable states? I'm never entirely sure when I do this. Is it when a young person who presents and there's no reason? Is it, do I wait on the second DVT or pulmonary embolism come along?
So this has changed recently, and this is a big push to not do hypercoag testing. So this is, the American Society of Hematology has Choose Wisely. Sky actually has this as one of their initiatives. And so the thought is that, is it going to actually change your management? So first of all, if somebody comes in and they have inherited, based on their history, that they have, there are other members in their family that have factor V Leiden. And so you may say, okay, we need, or let's say there's other family members that have had blood clots. So you say, well, I'm going to check you for inherited risk factors. The problem with that is that, let's say you find factor V Leiden in the patient that you are treating, and you say, okay, the rest of your family needs to be tested. If someone tests negative, there are studies that show that person is still at increased risk of getting a blood clot. So I think that gives them a false sense of reassurance. Oh, I don't have the factor V Leiden, I don't need to worry. I would say in cancer patients, I tend not to look. The place that I do send the hypercoagulable workup is for acquired causes. So that's anticardiolipins, lupus anticoagulant, beta-2 glycoproteins. The reason for that is because if a patient tests positive and they have a blood clot, and 3 months later you check again and they're still positive, they meet criteria for antiphospholipid syndrome, and that requires lifelong anticoagulation. Furthermore, the new agents haven't been extensively looked at in patients with antiphospholipids, so we're not sure if they're as safe and effective, so that's another reason for sending the acquired risk factors. Going back to the inherited, I do have family members that insist and say, I want to know what I have, and so sometimes I will do it. But this is a big push to move away from that and really test if it's going to change your management.
I gotta say, that's what doesn't make sense to the non-hematologist in the room, right? You're like, hang on, they've had a clot, I know they've got this thrombophilia, I know the risk of recurrent clot is high. Why would I not just put that person on extended therapy, as the CHEST guidelines say?
Wait, sorry, if they have...
So they have a clot,
Yeah.
They get tested, maybe because we did it before hematology got involved. Probably
they
put a
have
filter in
inherited.
too.
Okay.
And then they've got a known hypercoagulable state or thromophilia. That to the non-hematologist says that's extended therapy and probably merit, because we know the recurrence rate is high in general for VT patients,
Right.
and now they've got this extra factor.
So it hasn't been shown that it's higher in patients, so the thrombophilia certainly places them at risk in other provoking situations. So I decide length of anticoagulation, not so much on whether they have an inherited risk factor, but whether it was provoked or unprovoked. So a patient with a provoked below-the-knee blood clot, that's usually 3 months. Above the knee or a PE, if you look at the guidelines and look at the literature, their risk off blood thinner, once they stop their blood thinner, there's a number of studies that show the risk of recurrent clot can be up to 25%. So I go more by that. A person who has, was on OCPs and happens to have factor V Leiden, I'm not gonna, a young woman, I can't put her on blood thinner for the rest of her life. She's somebody I certainly will, if she had a blood clot on OCPs, she's gonna get a blood thinner during her pregnancy, but that's not someone that's gonna need to be on lifelong. So if you have a provoking factor, even if you have an inherited risk factor, that does not qualify you for having lifelong. Now there are ones that if you are double heterozygote or homozygote, that does increase your risk, and in those situations, that would change. And then if people have recurrent blood clots, that would be another reason.
I think one of the challenges for us too is that patients will have had DVT, been treated by us or not treated by us, and they'll come back and say, do I, don't I? We'll repeat their venous duplex, and they'll still have post-thrombotic changes, right? The DVT's not gone, and I think that's exceedingly common, right? That the DVT does not completely resolve. And then we're sort of stuck in this thing of, okay, you've got residual changes in your history. That's clearly a propensity for a new clot. Doesn't mean necessarily you have to be anticoagulated. In that case, we've occasionally been doing D-dimers, et cetera. I don't know if you do the same or ignore that part. Or
No. So we'll check. So in patients with idiopathic blood clots, if it's a below the knee, I'll check a D-dimer after I stop. So I'll check a D-dimer before I stop their anticoagulation, and then I'll check it at 1 and 3 months. And if it suddenly goes up and there's no other reason for it to go up, because remember, D-dimer is so non-specific. It's very sensitive. You're infected, you have pneumonia, can go up for so many different reasons. If it goes up and I don't have another reason, then I bring that person back and have a very frank discussion about whether to put them back on it. So I think D-dimer is a very good marker to follow in idiopathic blood clots. I have young people that have above the knee clot or even a PE are idiopathic, and they're young, and they're skiers. They want to do a bunch of stuff. They don't want to be on blood thinner, and kind of the compromise is, okay, we'll check the D-dimer, but they know they're at the risk is up to 25% of being off. So, but and in question to your having residual clot, so so people with post-phlebotic are at an increased risk of having recurrent clots. But again, I kind of look at the patient as a whole and figure out what are all their risk factors. So if this is somebody that had a blood clot because they drive their truck, 4 hours a day, and they're, 300 pounds, and even though it was provoked because they had, X, Y, or Z, if they have ongoing risk factors, I will keep them on a blood thinner. So it's all about weighing the risks and benefits.
Yes, sir.
So I'm one of those who do more thrombophilia profiles, and I use it just like you said as one of the risk factors. That decision to do lifetime anticoagulation or not is just one of the things, not the one factor. So just like you mentioned, they're obese. They have. I think I'm loud enough usually, but I was talking about doing thrombophilia profile and use it as one of the factors to consider whether to stop the anticoagulation or not. Along with the D-dimer, do they have any anatomical abnormality after trauma that they will not change? Did their venous Doppler normalize after the clot, or they still have chronic clot in there? In my mind, all these are risk factors for recurrence. And unless we're thinking only about cost, I'm not sure what the downside of doing the thrombophilia profile is. What's the downside?
Well, I think the downside is, definitely cost is one, but two, I think it gives you a false sense of, either you are or you're not going to make a decision based on that. I think it boils down to whether or not it was an unprovoked or provoked clot. So we know patients that have thrombophilia and provoked clot, they're not at a higher risk of getting idiopathic blood clots. They're at a higher risk in provoking situations. So you're presumably already going to, treat them in a provoking situation. So I think whether or not you knew they had factor V Leiden, if they have a provoked blood clot, let's say it was due to surgery, the next time they have surgery, you're going to prophylax that person probably. Well, at least I would. So I think it's a push because it doesn't necessarily change your management of things.
I guess it depends how you use the data, how you use it in the discussion. Because eventually, like you said, in many cases, you will have to make the patient participant in the decision. And always acknowledging they will always be at the high risk of having clot. No matter what the data is, the fact they had one, they're always at high risk of having another one. The question is how much. Just depends how you use it.
Yeah, but so that's exactly right. Because they've had one blood clot, I think they are at high risk. So are you going to think about them differently if they have factor V Leiden or not? You're probably going to treat them the same way because they've already had a blood clot and they are at that high risk. I think that's more of the thinking.
All right, last word to the heart surgeon, as it should be, of course.
Of course. Well, this is actually a question for Rachel. You know, it used to be the one question you had to ask is, do they need to be anticoagulated or not? And if the answer was yes, they got Coumadin. If they didn't, you didn't. And I mean, your presentation today was really very erudite and very eloquently stated, but now I'm more confused than ever. Because now there are so many choices. You know, do you use Coumadin? Do you use a direct thrombin inhibitor? Do you use a factor Xa inhibitor? And if so, which one? So, I mean, I'm just a dumb surgeon. What choice is the right choice?
Well, I would say the right choice is not Coumadin, right? So one of the new agents are first-line therapy. So I absolutely don't think, unless they have some contraindication. And then in terms of the choice, honestly, it often boils down to what their insurance will cover. I know that sounds odd, but it does do that. And I also just talk with people. I say, look, are you someone that can take once a day or twice a day drug? And are you someone that can give yourself a shot for the next 10 days? Yes or no? And are you somebody that, are you nauseous a lot? Are you going to be able to take your drug, your drug with food or not? So there really is, we don't have a head-to-head trial. And so saying, which one? So you might say, okay, which one do I use? So I would say, well, we have so I use all of them. I really do. I find that there was one meta-analysis of looking at all the new drugs in terms of bleeding, and Eliquis had a little bit less bleeding. So if it's someone I'm going to be on longer term, I might use that. If it's someone, that really is very busy, they don't think they're going to be able to remember to take a pill twice a day, I'll use rivaroxaban or the edoxaban one. But you should be confused because there is no clear data. You should be, because you can choose anyone you want, because they're all, and again, looking at the renal failure, hepatic failure, and then, in terms of the half-life and how quickly onset is, they're very, very similar. But they really are, they're all great options. And if somebody doesn't have a contraindication to any of them, then I use them. If somebody does have a contraindication, then I do go to the Coumadin. And in fact, the obese patients that I mentioned, where I had those 3 obese patients, I put them all back on lomocril as a bridge to Coumadin. I had to. But you should be, it is confusing. But the nice thing is, it's like being in a candy store, right? You kind of choose
Right,
whatever you want.
So we're in, this is like extra innings baseball. We're in free baseball at the moment. Last question. Go ahead.
Rachel, you didn't talk about monitoring in non-Coumadin patients. So do you measure 10A levels? Is that going to play a role? I mean, it's sort of counterintuitive to think that you can give standard doses to anybody and they'll have the same response. So if someone, for example, if someone has a clot on one of the DOACs, do you measure a level to see if they were adequately anticoagulated? Do you just switch them to another? But you don't really talk about monitoring.
Yeah.
And we're probably not ready for that yet. But
Well, that's a very good question. I think if somebody clots on one of the new agents, I put them back on Coumadin. In terms of monitoring, there is the dilute thrombin time that you can do with dabigatran. That's the direct thrombin inhibitor. And there are pretty well-established peaks and troughs as to where you should be. With the other ones, there are anti-10A levels, but the problem is there's no great guidelines in what is it correct. So I had a patient that had a Whipple, and she had also for a benign pancreatic mass, and then she had lung cancer, and then she was had a little bit of chronic renal insufficiency. She couldn't do the Coumadin. She refused to do that. She refused to give herself shots, and I was kind of stuck, like, what am I going to give her? And I ended up putting her on, I had to find out how much of her small bowel was removed, because these new agents are actually absorbed in the small bowel. And I found out that she had 25 centimeters removed, so I figured I had enough left, and I put her on it, and I actually checked an anti-10A level, hoping that if it was just anywhere within that broad range, that I could keep her on. She actually did pretty well, and she's doing quite well, but the problem is there's no great guidelines, and so it's not a great way to follow it because of that. But I have done it in times, But again, if somebody clots on one of these new agents, so if someone clotted on Xarelto or Eliquis, I'm not going to switch to one of the other ones because I'm not really sure why they clotted. I mean, nothing is 100%, but then I'll go back because I know I have the INR of 2 to 3 just in case maybe they were taking some drug that was inhibiting, the P-glycoprotein. Something was going on that they weren't metabolizing it the way that I thought they should.
This makes open surgical thrombectomy look like a walk in the park, Tom. And on that note, I think we're going to wind it up for the day. Sorry, quick one? We'll get it afterwards. Okay, thank you very much indeed for coming. See you tomorrow.
Oh, great.
Yeah.